This episode is brought to you by Midas Healthcare Solutions. Bridging compliance, patient safety, and proof of controlled substance waste has never been easier. Midas View provides proof and operational efficiency, the only diversion technology that delivers both, real-time visual verification of medication disposal, powered by AI and machine learning to detect improper drug wasting behaviors, seamless integration with your ADC, EMR, and diversion software, making reconciliation fast and identifying outliers with ease. And Rx Intercept, customizable sample collection with a secure chain of custody.
Welcome back, listeners, to Diversion Insights. My guest today is Dr. Max Feinstein. Max is a pediatric cardiac anesthesiologist, and he also has a YouTube channel that educates on all things anesthesia. So check that out when you get a chance. Welcome, Max.
Thanks, Terry. It's really a privilege to be here.
Today, we're going to just talk about anesthesia in general and his experiences coming out of residency and transitioning into an attending. As many of you listeners know, sometimes the OR is a little bit complex from our perspective. We don't really have a good window into it. And so I'm going to just talk with Max and ask him a few things about his training, what he sees in the OR, what we might take into consideration as we're thinking about looking for impairment or diversion in the OR. So let's just get started with a little bit of your background. Share that with us, Max.
Sure. So by way of background, I did medical school at Case Western Reserve University in Cleveland, and then I did the couples match, meaning I was paired up with my then fiance, now wife. We both came to New York for our residency training. I did my anesthesiology residency at the Mount Sinai Hospital, and then subsequently pursued a pediatric anesthesiology fellowship at Columbia University up the street, and then finished with additional training in peds cardiac anesthesia, and graduated in February this year. And I'm just about to get started back at Columbia as an attending.
Lots of school, lots of training for those little tiny hearts, right? Pediatrics, that's great. What kind of education did you get, if any, either in medical school or starting your residency on the topic of substance use disorder or diversion?
So I'll split that answer into two parts. So substance use disorder and then diversion. So I needed to learn about substance use disorder as part of the core curriculum in medical school. So that was really the first time that I had formal exposure to substance use disorders. That material is tested on board exams as part of becoming a physician, regardless of specialty. And then
is it, sorry to interrupt, is it substance use disorder, like recognizing it in your patients to assist them, or is it in healthcare professionals in the field?
I'm glad you asked. In patients.
Okay.
At least at the time, the curriculum that I had did not address recognizing it in colleagues. So the first time that I encountered any kind of education related to recognizing substance use disorders in colleagues was when I was in residency. And just to give a really quick timeline of what that looks like. So medical school traditionally is 4 years, and then residency in anesthesiology is also 4 years. The first year of residency, colloquially called the intern year, typically does not involve a whole lot of time in the operating room doing anesthesia. It involves other types of rotations. So when I started my second year of residency, which was when I was really spending the preponderance of my time in the operating room, is when I first encountered any sort of material from an educational standpoint about diversion in particular. And specifically, that was watching the wearing masks video, which I know has been around for a long time, the collaboration between the ASA and AANA. And I should also mention that at my residency program where I trained, that the residency program director, Adam Levine, is a very big proponent of creating a safe environment, making sure that our patients are safe, making sure that our colleagues are safe, and having open dialogue about recognizing diversion and making that as comfortable part of the workplace as possible.
Okay. So did they combine the education of the video with like kind of a Q&A and some conversation?
Yes. So as part of that, there was also a guest presentation by someone who is in medicine and did personally experience substance use disorder and have been diverting medications. I had started my residency, well, that part of my residency training 5 years ago at this point. I can tell you that the curriculum has changed at least a little bit. There is now a formal lecture that hits on really the major points of identifying diversion, identifying impairment, what to do about that if you suspect that, and also going over basically the latest literature on incidents and what the catastrophic outcomes can be.
Okay. Do they do that only now for moving forward, the new residents coming in, or did they also include people that have gone past that in terms of their class and had everyone there for that?
Everyone's included in that. That's part of the Grand Rounds presentation that is department wide.
Okay, fantastic. That's great. In the 4 or 5, or you're 5 years out of medical school, is that about 5 years? Have you had any experience with anyone in the OR, whether it be an anesthesiologist or even a nurse? Nurses are in there as well, being impaired or diverting?
So I personally have not seen or been involved with any diversion or impairment incidents, but there have been 2 that I'm aware of in the time that I was in training.
Okay.
People who I know who were involved with
Right.
that.
Okay. So that's pretty remarkable, actually, in just these 5 or so years that 2 people that you're aware of. That says something, I think, and it's an environment that is very high risk. And I'm glad to hear that your director, Dr. Levine, takes it very seriously and aware of the vulnerabilities of his colleagues, right? We're no different than the general population when it comes to anxiety, depression, and the stress that you have in the OR is certainly a factor as well. So it's nice to hear that he's looking out for the staff there and taking it seriously.
Yeah, I agree. And I think the important point in all of that is just the recognition at a high level in a program that it is a high risk environment. And while everyone who's working in that environment may have the best intentions, that when you physically have your hands on these controlled substances, people who are really motivated will find a way to get them. And denying that part of reality, I think, does a disservice to patients and healthcare workers.
Right. Yes. And anesthesia is so comfortable with these meds, right? And so there's that, I know how to use these and I know how to ration it and I can take care of this. So there's that piece of it too. There might be other people that are like, oh, I would never inject myself with anything. I couldn't, that's scary. But for those in the anesthesia profession, it's an everyday occurrence. And so you're very comfortable with that piece of it.
Yeah. And I would just flag the comfort part of it and say that while we do administer all of the medications you mentioned on a regular basis, it's one thing to be doing it in a controlled setting where the person who's administering it is not impaired. And it's another thing entirely to be self-administering in a setting that is not controlled. And what I learned by attending the Grand Rounds recently was by Ethan Bryson, who's an anesthesiologist at Mount Sinai, is the increasing prevalence of diversion and abuse of propofol. And the fact that it has a very narrow, I think therapeutic window is probably not the right way to address it, but for people who are abusing it, that it is not a very big jump from being awake and breathing spontaneously to dying.
Right. No, I think that, and I think that because of that, there's even anesthesia chiefs that I've spoken to recently that they're like, no, not propofol. Like, who would do that? But it is, it's a point to remember. And so it's not a controlled substance, but it's something that we need to be mindful of, should be locked up, and there's a chain of security that we really must. I think that leap is where it's easier to get their hands on it because it's not as monitored. And so then it puts them at more risk because it does have that narrow band. Yeah. So talking about access to meds. So what is it like in the OR for a resident versus an attending? How does that work in terms of handling the medication? Is the resident always in charge of that, the oversight of it as an attending? You've done both now, and you're fresh into the attending phase. So talk to us about that.
Yeah. So I'll address those questions. And before I do that, I'll just take a short period of time to help people get familiar with the different terms, just Perfect. Appreciating that you have a really wide audience that encompasses a lot of different aspects of healthcare. So for someone who is for a physician who is in training to become an anesthesiologist, so already graduated from medical school, doing the specialty training, so that's the anesthesiology residency, those trainees are called residents. If someone chooses to pursue additional training afterwards, and then pursue a subspecialty, then those trainees are called fellows. And then once someone has completed all of their training and they go on to work without trainee status, they're called an attending, in this case, an attending anesthesiologist. And of course, there are other healthcare workers who are providers of anesthesia. So that includes nurse anesthetists. And so I'll speak to working with nurse anesthetists as I have as an attending. But in other places, there are also anesthesia assistants as well that you'll see as abbreviated as AA or CAA. So the way that the structure works, the care team model works in a lot of places, is that an attending anesthesiologist will be overseeing one or multiple operating rooms. And so obviously, you can't be in two places at once. So that's where the care team model comes into play. So if I, as an attending anesthesiologist, am covering two operating rooms, then there has to be people who are in both of those operating rooms. So at a large academic center, that might be two residents, or it could be a combination of residents and CRNAs or fellows. And in many practice settings, particularly non-academic settings, there may be one attending anesthesiologist who's overseeing 4 operating rooms that are staffed with CRNAs. So there's my point in saying all this. One is to make sure that everyone is familiar with the terminology, and 2 is to paint a picture that there's a lot of variation in terms of how rooms are staffed. And so then going back to your question of what actually happens with the controlled substances, who gets them, who administers them. So there's also a lot of variety with that. The picture that I'll paint is what my experience was as a trainee, which based on talking with other people, I think is pretty common, which is that typically the resident or the fellow or the CRNA will be the person who gets the medication from wherever it comes from. So whether that's the ADM that's in the room, or if there is a pharmacy model where providers are picking up medications from a pharmacist and then returning those at a later point. It's typically either the trainee or the CRNA who's getting them, and not the attending anesthesiologist. And so I am coming off the heels of the last 5 years of my training, where I was the person getting the medication every day. And I've worked I've worked at a number of different hospitals and rotated at a number of different hospitals. And in my experience, I have had both of the models where there was, an ADM that was in the operating room. I worked at a hospital where there's an ADM that's in the core in the cluster, but not in every operating room. And then also in a model where there are no ADMs and the medications are picked up by the whoever's administering it from the pharmacist. And so in terms of who administers the medications, that also really can vary. Generally speaking, the mandate for the attending anesthesiologist is to be present during the critical portions of the case. And from an anesthesia standpoint, obviously there's a lot of leeway in terms of what is defined as critical. If a patient is having any sort of procedure done by the anesthesia team, so that would be, for example, intubation, nerve blocks, an arterial line, a central line, that would be the kind of critical procedure that an attending should generally be present for. But that leaves a lot of room for other portions of the case where the attending can and very frequently does leave the operating room to go do other things, ranging from being in the staff lounge and having their computer terminal open, to going and seeing the next patient, or post-oping the last patient, or going and inducing anesthesia in one of their other operating rooms, or getting breaks and so forth. So that range of activities an attending can do means that during the majority of a lot of cases, it's the resident, the fellow, or the CRNA who's administering medications and making decisions about when to administer medications intraoperatively. As an attending, I typically am only administering medications, and mind you, these are medications that the trainee has gotten out, not that I have signed out under my name directly. I'm typically only administering medications during induction of anesthesia, and if I'm getting the resident out for a lunch break and I need to administer something, then of course I'll do that. But in my limited experience as an attending, it's not that often that I'm administering medications, save for the beginning of the case.
Okay. As with a resident removing and attending technically responsible, what does it look like in the OR in terms with on that sterile field and you've got the medications out? Is the anesthesiologist typically head of the bed? This is my stuff. Nobody can get to it. Only like I am here and I see it, and nobody could take this right from under my nose, assuming you're in a procedure, right? I'm not talking about prepping ahead of time or going to the PACU and leaving it out. I'm talking about in the procedure.
Generally, yes, that's the case. It should always be the case that medications are not on the back cart, whatever the back cart is, whether it's an anesthesia cart or the ADM. Any medications that are opened for a patient should be on the anesthesia workstation, which is typically, and there are exceptions to this, but for the most part, there's what we would call the ether screen, the big drape that's up between us and the surgical field. And so really the only way to get into that little nook is to get past there's usually a chair, although in cardiac operating rooms, not as frequently, but there's the chair, and then beyond that is the anesthesia workstation. And on top of that is where medications are being stored for the patient who's currently in the room.
Okay. I have heard it said as an excuse sometimes, at the end of the case, there's so much going on, I don't have time to whatever, has something to do with meds and clean up. Is that typically the case in the OR? Is the anesthesia provider extremely busy at the end of the case?
It's really practice dependent. Okay. It might be instructive for me to give you a quick timeline of what it looked like when I was a trainee setting up for a case, and kind of what's going through my head and what's happening with the medications, right? So assume that surgery starts at 7:15 in the morning. And, so I get there at 6:30, I get everything set up. 7 o'clock, I go see the patient. 7:15, we're in the operating room. And, imagine this is it's a cardiac surgery. It finishes at 2 p.m. and there's another surgery that's scheduled afterwards. And so the process of getting set up, seeing the patient, and then getting started, hopefully by 3:30 p.m. Is what's in my mind. So as the first case is finishing and we are, maybe emerging the patient or maybe, going to the ICU with the patient intubated and sedated, I want to, in that particular circumstance, I want to travel with all of the medications that I need to have available with me on what's typically a pretty long journey to the ICU. Go through an elevator. There are periods where you don't have any assistance if you need anything. So you want to have a little mini pharmacy on you. So I go to the ICU. I've got my bucket of meds and my resuscitative equipment. I drop the patient off. I get signed out to the ICU. And what's going through my mind is I need to get back to the OR. I need to turn it over. I need to go see the next patient. And in so doing, I also have my bucket full of meds from my last patient. Yeah. I am thinking about making sure that I don't lose anything, that I don't accidentally throw something away. I want to dispose of everything that's not controlled so that I don't have to carry it around with me and I don't risk reusing a syringe. So then I go to the sharps container and I'm getting rid of the esmolol and the epinephrine and everything that's not controlled. And I just mention this because there are a lot of points at which it would be possible to make a mistake in terms of throwing something away that I shouldn't have, or misplacing something. And there is definitely going to the question that you asked. Oftentimes there's a production pressure and a lot of moving parts, and primarily making sure that the patient's okay, right? I mean, mm-hmm. Until the point that I hand off to the ICU, I'm responsible for the patient. And so that's what I'm thinking about first and foremost. And so then there can be a hurry to get things turned over and then get back into the operating room so that you can start the second case. And that's going to be a long one as well. And then by the time that ends, you go through the same process, go back up to the ICU, you've got the patient's medications, and now it's 11 p.m. and you would like to leave. After you've safely signed out the patient, then getting home is a priority. So there can be a hurry to get out of there as well. And I do think that it's the case in a lot of hospital systems or ambulatory surgery centers that there is quite a bit of production pressure that affects everyone, and that includes anesthesiologists, and that could certainly add to feeling hurried to turn a case over.
Mm-hmm. Is there anything in general that you have thought, if only the hospital would change this, or if this expectation was modified, it would make it so better, right? I mean, I'm a big proponent of, you have to follow the regulations. You've got to keep it safe. This is real life, though. We have to figure out how to work within the regulations, but to make it so that you can do your job and do it safely. So is there anything that you have thought more than once, man, if they would just change this, it would make a difference?
Definitely. So I'll preface my answer by saying that I do not have an extensive background in studying diversion or methods to intervene on it. So what I'll say is just my own opinion. It's not based on data that's in the literature. Having said that, the thought that has crossed my mind on many occasions, having gone from or worked in one system where I was returning controlled substances to a pharmacist at the end of the day, to working in another system where I was, I guess, technically returning controlled substances to the pharmacy as I was turning them into the ADM, but not giving them physically to a person or having someone witness wasting. And I have to say that the setup of trusting the witness type of wasting strikes me as something that's probably not effective in curbing diversion, because as I've said, I've worked in multiple institutions, and what I've seen across institutions is that people don't necessarily take that seriously, and so it ends up oftentimes not being a witnessed waste.
Right.
And my thought that I've had repeatedly is there has got to be a way to make this safer, because it just strikes me as an extremely easy way to divert controlled substances.
Right. The witness doesn't take it seriously. And then if the primary person wants to divert it, they even if the witness did take it seriously, they don't know what's in the syringe necessarily. Right?
And I was just going to bring that up. There's no way to know. So
right.
It seems like the premise of that system is flawed to begin with.
Right. So intuitively,
my non-expert opinion on that.
Yeah. So intuitively, from your experience and what you've seen, if you hand it in to either put it in a return bin in its entirety or hand it to the pharmacy, whichever, that mitigates diversion more than grabbing a witness and doing it on the spot, is what you're saying.
That's my intuition. And I will just signpost one of the potential downsides to that, or maybe not a downside, but a complaint that I think is a very legitimate complaint from the anesthesia side of things, which is that, depending on how the waste is handled, if the pharmacy, and I will say I am a huge proponent of having a collaborative relationship between pharmacy and anesthesia and all of the other stakeholders, of which obviously there are many. But if the pharmacy is taking their job seriously and they note a discrepancy of, what's their tolerance going to be? A 1 milliliter, a half a milliliter, right? And then as an anesthesiologist, if I'm getting like 3, 4, 5 emails, a month, a week, and I have to then go over to the pharmacy to address each one of these, I understand that comes from a place of wanting everyone to be safe, but taking that extra time out of the day is challenging because of the everyone's busy at work, right? And if I've got a couple operating rooms, 3, 4 operating rooms, then going to the pharmacy, which isn't necessarily closed, and having a conversation with the pharmacist ends up taking a lot of time out of the day and can be a hassle. And I think that I would imagine that would be something that other anesthesiologists would be challenged by as well.
Yeah, that's an interesting point. Where is the disconnect on that in terms of, it should all be accounted for. So if there's a half a cc or a cc that is missing, what would be the reason from your perspective that it's missing on your records, on paper?
Yeah, something as simple as when you're physically pushing the syringe and you're aiming to inject 3 out of the 5 milliliters in that syringe, and you just happen to go to 3.5. You should chart obviously what has been administered, but those little things can add up, and maybe it's even a little bit less of a discrepancy than that. Maybe I administer 3.25 mLs, and I chart that it was like 3 mLs, so I'll just call it 150 micrograms of fentanyl, and multiply that times 2 over the course of a 6-hour case, and then all of a sudden, 50 micrograms of fentanyl appears not to be accounted for.
Okay. Is something like that, I can see that definitely happening. Is something like that where every anesthesia provider would run up against that? So are people that aren't getting the emails from pharmacy just like adding their total up and like, whoop, okay, I ended up with less than I expected, so let me just say that I gave it? Are they just charting it? Or, I mean, what, either if that's a thing that happens regularly, then everybody would be getting emails. So obviously, if there's one person or two that are constantly short, they're going to stick out, right? And so how are their colleagues making sure that that's not happening to them? Or is it happening and they're just changing their numbers?
Yeah, I'm not sure, to be honest. I could imagine that there are folks who just change the numbers in the chart to reflect what's in the syringe, or people
Yeah.
want the chart to reflect what was in their mind, because it's not an uncommon thing for charts to be opened by multiple people who want to see what's going on in the case. And if there was, say, more fentanyl administered than maybe whoever was giving it wanted to administer, they might not feel good about other people seeing that more was given when perhaps they should have given less.
Right. Yeah. Yeah. No, I see. But it's a good example of, again, having the conversation. Don't assume that you know what's going on. If you have a conversation and you find out, yeah, it's pretty easy to give a little bit smidgen more than I planned, and this was 3 smidgens that added up to something, you know.
Yeah, and the other area that this probably accounts for that a lot more frequently is the fact that when we administer medications, there's a lot of dead space in the tubing for the medications, and particularly in pediatrics, there are different names that you'll encounter for this, but when you connect microbore tubing, or sometimes people will connect 2 pieces of microbore tubing that maybe each have a volume of 0.8 milliliters. And so then you have 1.6 milliliters of dead space between where your syringe is and what the patient is getting. And so, thinking about handling that, obviously, you administer whatever medication you want to deliver and then follow it up with a flush. But even still, there can end up being some amount of medication that remains in the tubing, particularly for infusions that are not going to be flushed. And if I've got a fentanyl infusion that is running for 5 hours, then at the end of the case, I maybe have 1 or 2 microbore extensions that are filled with fentanyl, and right there is going to account for at least a milliliter.
Right. Yeah, especially in those pediatrics. So is there any one thing that you can think of would be a red flag in the OR that really you should look into if you see this going on? One thing that I saw recently, and so here's a question for you too, that if an anesthesiologist is pulling meds before they're ever interviewing the patient and talking to the patient, is that a red flag? Or is it usually so consistent that most patients, your interview does not make a difference on what meds you're going to pull? So that's one example. Are there any red flags that you would think of, like, if you see this happening, you probably should look into it?
Yeah. So in response to the specific question about pulling meds before interviewing a patient, I think that's totally reasonable to do. Okay. There's only so much variation that you'll see based on a patient's weight and age and some other factors. For a patient who's coming in for for an open heart surgery or coming in for a cholecystectomy, there's a range that I would expect to see for a patient. And in terms of other red flags, unfortunately, I don't have enough experience identifying, what I just haven't seen anything in my own practice that has struck me as a red flag. So it's just not something that I could speak to, unfortunately.
Yeah,
or maybe fortunately.
Yeah. It was just, if you see obviously there's the induction phase, but if you see another dose of, say, fentanyl at some point along in the case, will you also see vitals or something with the tourniquet happening? If none of that is present, is that something that would kind of make you go, let me check another case and see? Or if they have a nerve block, would you expect less other meds to be going with that patient, those kind of like big picture things. I'm sure there are a lot of, variables though that you need to take into consideration.
Definitely. As far as the way that I look at a case, personally, I tend to focus more on what's the cumulative dose of a medication that was administered over the course of a case. And I have, primarily because I am trained in pediatrics, I tend to think a lot about weight-based dosing. So, if I am taking care of a patient and they have, I'm working with a resident, and the patient came in for a cholecystectomy and received more than, 3 micrograms per kilogram of fentanyl, then I might start raising an eyebrow and wondering what's going on. And of course, I'm taking a look at the records, even if I'm not in the room, as you pointed out, to see what's going on with the patient's vital signs. If the patient's receiving an opioid in the absence of any sort of vital changes, that doesn't immediately strike me as a red flag. I think that there are a lot of anesthesiologists who are trained to think that there's a certain dose of opioid that should be delivered throughout the course of the case. It might be prophylactic, to administer another, half mic per or 1 mic per in the middle of the case. It might be the case that a resident is thinking about not wanting to administer more muscle relaxant towards the end of the case because they would like to be able to get the patient breathing spontaneously relatively quickly. So in lieu of administering muscle relaxant, they might administer more opioid to keep the patient from moving, but without having to use muscle relaxant to do it. So I think there are a lot of reasons why an opioid in particular might be administered in the absence of vital changes. So that, as I said, doesn't strike me immediately as a red flag, but looking at the case in a big picture and really understanding what the total dose of medication that was delivered, that's what would clue me into something being discrepant with the norm.
Okay, that makes sense. And you've just, again, pointed to the need for collaboration, right? We can't, whoever your diversion is monitoring for diversion cannot come to any assessment without having somebody who really understands what's happening in the OR, and when it comes to being an anesthesia provider, to review those records and that collaboration to determine if maybe there is something that requires further investigation, or nope, this looks reasonable.
Yeah, and I would say that absolutely goes both ways. I will tell you that I knew nothing about who is practicing on whose license as far as medications being administered until I started watching your podcast and gaining an understanding of the fact that, in fact, the pharmacy is subject to inspection by the DEA and that they are operating under their own license. And I would imagine that there are a lot of anesthesiologists who just don't have an awareness of what that structure looks like, because it's not something that comes up in conversation or in education, I think, for a lot of us. So, increasing understanding and awareness on the anesthesia side of things, I think, is tremendously important.
Yeah. That's true. Yeah, the director of pharmacy does not want to micromanage the anesthesiologist, but they do hold ownership for all those meds. So there needs to be a conversation.
Yeah, and that's something that I think can feel really lost on anesthesiologists, because when I'm getting a medication out, I feel like I'm the one who has ownership of those meds.
Exactly.
I mean, and at the end of the day, I think chain of custody is a really great term, because it encapsulates the idea that there is a chain. We're all linked together, and there are certain points where one person has custody, of course, of the medication, and I think it can be easy to feel like there's not a chain, that it's just us who has custody of the medication.
Yeah, no, good point. You had mentioned you had one specific example at some point in your residency where you were called into the office for some waste that you had turned in. Can you share that with the listeners?
Yes. So I had just started my pediatrics rotation, and I was already a little bit on edge because for I would say the majority of trainees going into a peds OR can feel very intimidating for a multitude of reasons. So this was my first day, and I remember the attending who I was working with, who's a good friend now, and I got an email after we started our first case from my program director, and it was very. Let me just make it really clear: this was not a confrontational email. There was no finger pointing, but I knew something was wrong because the email from my program director was, "Can you please come to my office at your earliest convenience?" So,
no underling likes to hear that from the right.
Yeah. And so, I mean, I felt really concerned because I had no idea what I might have, screwed up. And I walk into Adam Levine's office, and he says, Max, there was a return that you made to the pharmacy. There was a 5 ml syringe of fentanyl, and it was tinged white. Can you please tell me what happened? And I thought, oh yeah. I mean, I remember this had just occurred, right? Because this was a medication I had turned in like a day or two prior. And I said, yeah, I had drawn up the fentanyl. I was getting ready to administer it to a patient. I connected it to the injection port, which happened to be the same injection port that I had been administering propofol. And then I decided not to give the fentanyl. And so then I took the syringe off without having administered anything, and I capped it, and I identified that as a used syringe, and I turned that back into the pharmacy as a used syringe. I either didn't notice or didn't strike me that it would be a red flag to turn in what I was identifying as 5 mLs of fentanyl at 50 mics per ml, but it was tinged white. And so this had gotten the pharmacy's attention. And I'm not familiar with the assays and what sort of technology is available and what may have changed in the 4 years basically since then. But they weren't able to analyze it in-house. So they had to send it out. And so this had already been done at the time that I was talking with Adam. He said, we've already sent this off. And so if the syringe contains what you say it contains, then we'll never have to talk about it again. And we never did. But I would just highlight that I was so impressed, especially now as I'm learning more about diversion and prevention, that they and I say that because it really is a collaborative effort between pharmacy and leadership in my program, identified something that looked like a red flag in very short order, and intervened on it in a way that was non-threatening, that was non-confrontational. At no point was I accused of anything. It was a very open conversation with my boss, with my program director, where he just wanted to understand what happened. And I told him, and that was it. And the only part about that to me that was scary was the time period between being told that we needed to have a conversation and then having that conversation, just because I couldn't have imagined what it would have been about. But it's an experience that really stands out to me as a way of safely and in a collaborative environment stewarding prevention of diversion.
Yes, I think that is we will end it right here. That's a great summary, a great example of that collaboration and an institution that's taking it seriously, not afraid to have a conversation, just asking you factually what happened here, trust but verify to, make sure that's the case. And clearly the pharmacy and the chief were, working together, which is such an important collaboration as well. So I think that's a fantastic example. All right. Thank you very much, Max, for spending this time and giving us a little bit more insight into the OR.
My pleasure. Terry, thanks very much for having me. It's been great talking with you.
You too.
A special thanks to our sponsor, Midas Healthcare Solutions. If you want real proof delivered efficiently that your controlled substance waste is compliant and supports patient safety, Midas View finally provides it. Stop at their exhibit at the IHFDA Annual Conference in Frisco, Texas, September 29th and 30th, or visit www.midashs.com to schedule a demo. When it comes to controlled substance compliance, seeing is believing.